you for subscribing to the Frequency Specific Microcurrent podcast. FSM is a breakthrough tool for medical practitioners who feel stuck with limited treatment options, especially for complex issues unresponsive to conventional care. FSM training is the best continuing education course for medical practitioners. Get our free introductory webinar at frequencyspecific.com/about or find FSM trained practitioners at frequencyspecific.com/find. Here's Dr. Carolyn Kim Pettis.
Hi.
Hi. You're back. No
Oh.
sound. Oh, I hope someone said there's no sound. I can hear you.
I can hear you.
Good. So we can hear each other.
They hear us.
It would be nice if everybody else could hear. So if some other people that are here live would like to say they can hear us. Hello. Good. Okay. Some people can.
Okay. No sound.
Thank you.
Hear you both. Yay.
Okay.
We're back on. Hi.
Hi.
I didn't mean to be late.
That's okay. That's okay. That's what today's been a bit of an interesting one, but that's.
Tell me about your day.
My day has been interesting because I had some clinical issues in which I had to vacate our space in Livermore very quickly because ceiling and wall was falling apart.
I hate it when that happens. No way.
Rain in California does funny things, especially to old historical buildings.
Oh, raining.
So I'm homeless right now. I'm mobile and we have a great Bay Area community. So I'm actually moonlighting at different clinics, probably for a while.
I've got a room. I've got a gym.
I know. And that was one of the reasons why I wanted to talk to you today, but we will set up our call a different
Afterwards. Okay.
It's funny how I had been toying with moving for some time. And then sometimes the universe just smacks you upside the head and says, yes, now is the time.
Okay, we'll have that conversation later, I think. That would be a fun conversation.
Yeah, so lots to catch up on, but you and I can do that at another time.
Okay.
But I'm spending some time at home, a little extra time at home because I've been forced into it. Time at home typically means time to play with PowerPoint slides and putting the finishing touches on the rehab courses, which pulling up case studies, because when I'm thinking about the take homes, when I listen to you lecture and when we go to the advanced and we hear these amazing people talk, yes, the content is important and yes, the slides are important. But I think what so many of us really absorb in our hearts and in our souls are the case studies. So I spent today going back and pulling up case studies and taking chart notes and putting them into slides, because I think that's really a valuable part of teaching. And just when I thought I was going to pull back on the clinic and put more into teaching, I thought, why do I have to pull back on the clinic? Because the reason why I think the course has changed and evolved and it has improved is because I can take the nuggets of what I do clinically and talk about it in the course. So the stars are all aligning in the last couple of weeks.
That's how exciting.
And I got some new hats made up. So they're pink, they're girly.
Okay. Girly hats are good. There are girl athletes.
Yeah, there are. Yeah.
Guys that don't mind wearing pink.
Yes. So I have options.
There you go.
So there's that.
I am, we are going to be in Costa Rica for 2 weeks next year.
Okay.
I love the part where you said, book it, especially when you heard about the drunk monkeys.
It was all of it, between Danielle and Wendy sending me pictures and you sending me pictures. And
my background is a little different today than it was last week.
Yeah. What was so cool about last week was just watching the sunset behind you and it going from like Jurassic Park to like something else. Very magical. Yeah.
Just a black screen.
Yeah.
It gets dark summer and winter at 6:00.
Right.
Twilight at 5, 6:00.
Let's talk about Costa Rica. How did you find this place? What is the place? Let's just talk about it for a second.
Joseph Mikrot owns Anamaya. He and his business partner bought the house and then in a year built all the cabins down the side of this steep hill. Like I climbed more stairs than anybody should ever climb, I think. But anyway, and I got the room closest to the top. And he emailed me and he said, I want you to do a course in Costa Rica. And I went, Costa Rica? Does anybody actually live there? And then I have two friends of mine that moved to Costa Rica. And so I went to visit them, and I have another friend that bought a condo as an escape, and she was down in the Nicoya Peninsula. And the Nicoya Peninsula sort of is a little thumb down at the bottom of Costa Rica that is a blue zone, where I think there's 6 of them in the world where people routinely live to be more than 100. And she bought a condo in, name fell out of my brain. It's a surf touristy town.
Okay.
And it's like it's a town. Although they don't exactly have street names and they don't have street numbers, but that's a whole nother conversation. Anyway, and so I went to visit her, and then I went across the peninsula because Joseph is Anamaya is on the other side, and visited and went, okay, this is one of those things where I'm going to do a seminar here. I really almost don't care if anybody comes. I'm going to be here. And so Kevin, and I'm taking Wendy and Danielle with me. And they went, why do we have to go to Costa Rica? And then they got there, and I don't know if you got to see their faces, but they're like,
Oh, yeah.
all melty.
Melty.
Melty. There's something about the environment. The drunk monkeys were Gwen Bolger came from NTC.
Yeah.
And she brought, did we tell that story last week?
No.
Oh God. A thunderstorm came through, and I took 2 meclizine and a Valium and could not stay upright. And I thought, yeah, I'm going to go to bed. You guys occupy yourselves for an hour. I'll be back. It's going to be just a longer break than usual. And Gwen Bolger brought chocolates filled with Irish whiskey. The howler monkeys are really smart, and they figured out that they could open the sliding glass doors if you didn't lock them. Well, most of us didn't think of locking them. And so the howler monkeys opened her door when she wasn't there. And they look around. And we know this because one of the capuchin monkeys, the ones with the yellow faces, tried to break into Danny's room. Was it Danny's room or Wendy's room?
I thought it was Gwen's room.
No, it was one of our girls. Anyway, one of the capuchin monkeys. The girls were inside and filming, and somebody was filming it from the outside. So the monkey opened the door.
Oh yeah.
And he looked in. Oh, pulled back. He looked in and he moved the curtain and he pulled back. And while he pulled back, the girls closed the door. Well, there was nobody in Gwen's room. And so the hella monkeys got in and they saw chocolate. That sounds good. And they ate the whiskey chocolates and then left. And while I was in my room recovering from Meniere's, the howler monkeys put on quite a show for about an hour. If you can imagine drunk monkeys swinging, and the mom had the baby and the male and the juvenile. So it was like a whole family. Dad, 2 teenage boys, and mom and the baby, all doing circus routines in the trees outside, of people who are filming. It was great.
I mean, if that's not a reason to go to Costa Rica to take our course, I don't know what is.
And it's a good reason to maybe have Gwen send, if she's not coming, Gwen send whiskey-filled chocolates, and maybe we can leave them out on the porch or something for them in case they make some.
That's a great idea.
Yeah, it's cool.
I was looking, as I'm putting the calendar together for 2026, I'm going to be going up to Canada a little bit more to teach because I'm a Canadian. I realize Canadians don't want to come down to the US right now, so I will come to Canada. Easy enough. My friends and family are more than happy to see me. And as I was plotting out the map and kind of doing a little bit of research about seminars, we're seeing this trend of people wanting to travel again for seminars and doing these kind of destination retreats, continuing education. Why not? If you're going to travel, let's travel somewhere exotic and warm and fun. So maybe Winnipeg, Manitoba is not so exotic, but it's my hometown and I'm going up there. But Costa Rica definitely is. And then we've got Europe and so many great places.
And the seminar schedule in Costa Rica was Sunday, Monday, Tuesday. So we do ours Wednesday, Thursday, Friday, Saturday, Sunday. And people have to leave early on Sunday, and by Friday night, they're really fried. And in Costa Rica, it was Sunday, Monday, Tuesday. We had Wednesday off because they have spa services and people want to go into town and go shopping. And then Friday and Saturday. So you still got 5 days, but there's a day break.
Yeah.
And it made so much sense. I'm pretty sure that we're doing that in the US this year. Because basically, if you travel on Monday and you have maybe Tuesday to recover from jet lag, you lose the whole week anyway.
Sure.
So why not do Sunday, Monday, Tuesday, take a break Wednesday, go see the gorge, go in and see the Japanese garden. Portland has got a lot of stuff to see.
Yeah.
And then do Friday and Saturday and leave on Sunday. No,
Yeah.
Thursday, Friday. Sunday, Monday, Tuesday, take Wednesday off, do Thursday, Friday, and then you get to fly home Saturday. And we don't miss the visceral section as much. So
As much.
we're going to try that this year and see if Americans will go for it. We're such workaholics and we really need to get over it.
No, I agree. And I think it's just like when I yell at my athletes for overtraining. I said, you need to take a day off. And they're like, no, day offs are for blah, blah, blah. And I'm like, okay, let's rephrase it. You have an active recovery day. And they're like, oh, what do I do on an active recovery day? Like, nothing physical, anyways, but you have to give them restful ideas to do. But because we can't, and I explain this to my athletes and to my teenagers, we can't just keep making withdrawals. You have to put a deposit in once in a while.
Yeah. No, it was amazing. I got a hot stone massage and walked into town and they had passion fruit gelato.
Ooh.
It's a 5-minute walk into town. Actually, it's more than that. They have a shuttle that drives us in.
Yep.
I got a scoop of gelato and walked down the street and bought a necklace and the necklaces are handmade macrame.
I think you had it on with one of the podcasts. It was very pretty.
It was last Wednesday.
Last
Yeah.
Wednesday. Yes.
And yeah, it was pretty cool.
Great.
Yay.
So that's Costa Rica. That is not coming up as quickly as the advance, though. The advance
Oh,
is
no,
right.
I just saw John Muskie and I said, I'll see you in March. And he went, oh yeah, I'll probably start on my slides because he'll change. I asked him to change it now because he does a great job with the anatomy and the neurology of how the neurology needs prism glasses.
Yeah, I was just going to say, why don't you, for people who are just watching or just listening, do you want to just give John Rusky a little bit of an introduction of who he is? And
he is an optometrist and he is a fellow of the College of Optometry and Visual Development. So he does prism glasses for people like me that have Meniere's. And every single class, because I have an excuse, there's about 20% of vestibular injury patients. It's not every vestibular injury patient, but it's about 20% of the vestibular patients we see who have vestibular injuries get sick when you run the concussion protocol with 94 and 94 is the only frequency for some reason that makes them sick. And they may not get sick. The challenge is they may not get sick at the time or may not tell you about it because they think it's from something else. So I had a patient that the first one that ever happened on, second one that ever happened on, she felt fine at the time. And the next day she came in and said, I'm just having a detox reaction from all the work you did on my shoulder yesterday. I was okay. That was Tuesday. And Wednesday, I'm still nauseous. So I gave her a detox pill. And then Thursday, she said, I am still nauseated. And I said, let me look in the chart. And the only thing we did different on Tuesday was we ran the concussion protocol.
Mm.
Across the hall, and I got a meclizine and gave it to her, and the nausea went away. That gives us an excuse to teach the information about vestibular injuries. This class was 16 people. Every single class, every single time in the last 20 plus years, 20% of the class, no matter what the size, it's 20%, are positive for vestibular injuries. I go through the vestibular section and ask, okay, how many of you recognize yourselves? You can count, it's just statistics, it's just 20%. How many of you recognize patients whose symptoms you have missed? And it's 80% of the class. I had one speaker one year that didn't work out, and then Dr. Reski explains the neurology of how it is that vestibular injuries interfere with balance, cognitive function, reading, why they cause anxiety, why they cause nausea, where in the brain they're connected. That's perfect.
Yeah.
How you recognize them. So he gave us a paper test, and I use the short version because vestibular patients have trouble reading. So I don't want to give them 28 questions. I give them 18. And the 18 is easier to score. If you're over 18 out of 18, you need to see you need prism glasses. So he's going to do more on the diagnostic side. How do you recognize it? I have trouble reading since the accident. I'm not sleeping since the accident. I have an anxiety disorder. And practitioners who go through the vestibular section, who everybody goes through the vestibular section, practitioners that go through our vestibular training know why patients can't read. They know why they're anxious in Costco. And it turns out that nobody else recognizes it. Nobody. We were lucky to have 3 of the world's top vestibular specialists here in Portland when I was treating chronic fatigue and fibromyalgia patients. And so I learned from them because those chronic fatigue patients came in with reports from these 3 guys. And so I learned how to screen for it from the neurologist. And then I started screening for it and I started finding it over and over again. And then we had the first 2 patients that year that got sick. And it's not always right away. The first one, it was right away. But the one that got me was the one where it was the day after or the day after that, and it persisted. And now, when routinely, once every week, once every 2 weeks, I get an email or find it on Facebook. Hey, I treated somebody's shoulder, low back, whatever, and they had a headache the next day. They didn't feel good. They've have all these symptoms. And I said, did you run the concussion protocol? Yeah. Did you do a vestibular screen? Oh, no, they forgot that part. So I do a vestibular screen on absolutely everybody. And when the patient comes in with sprained my ankle. I fall a lot. So you go to take a step down a stair and the stair's not where you expect it to be because you don't see correctly. And so I fall a lot. I have an anxiety disorder. I don't sleep, all these sets of symptoms. And automatically I hand them this paper test. There's somebody who came in this last week. No, it couldn't have been last week. It was in Costa Rica. It was Monday of this week. And she had 2 or 3 of those symptoms. We've gotten so we send out the BIVSS, Brain Injury Visual System Symptom Questionnaire. We send it out with all of our new patient. Her score was 50 over 18.
Wow.
And she's seen neurologists, she's seen GPs, she's seen her optometrist told her she had a convergence disorder and she just needed to do these exercises. And her optometrist missed it. My son, Adam, had an airbag go off in his ear, and his optometrist told him he had a convergence disorder. Rusky is my optometrist, Adam's optometrist, and so he has done an amazing job. The first speaker was not so good, but Rusky's been, and I have had him come to every single advanced ever since.
Yeah.
Because our practitioners are the only ones, and there's only 5,000-6,000 of us in the world, in the whole world, in 23 countries, which means we're still at about 2,300 in the US. And think of 20% of patients who have vestibular injuries,
Right.
including the practitioners in the class.
Right.
That's just nuts.
And one of the things I wanted to just add my 2 cents is I think back to whatever that advance was years and years ago, where I first met Mary Ellen Chalmers, and she was talking when we had 2 tracks, and it was really mean of you to make us choose where we wanted to go.
I thought it would be a good idea. What does a functional medicine person want to hear about shoulders or low backs?
But
Well,
everything is connected to everything, and we need to learn everything. And
yeah.
so what we talked about the last podcast about massage therapists not being able to diagnose, you don't need to diagnose a vestibular disorder. You don't need to have the skill set to treat a vestibular disorder. So a lot of the things that you learn at the advance, whether it's about root canals that are failing or vestibular issues or prism glasses, is to just give you the tools to, like you said, recognize and screen for something. And then when I make the call to somebody and I say, hey, somebody has this score on the VIBSS, or somebody has these symptoms in their mouth, what do you think? Again, like if we are thinking about patient care and getting that patient better, to have the tools to reach out to an expert in their field is never a bad thing, especially when you can give them something, I don't want to say diagnostic, but diagnostic or
Concrete.
screen.
And you can say to a patient, if they have the BIVSS, or you can do a vestibular screen and say, most people don't react that way. And you might want to see, there's this special optometrist in the city. I am a massage therapist. I can't diagnose you, but what I know is most people don't do that when I do this. So you might want to go see this guy.
Right. And you never look weak or bad by saying that. I do that all the time. I said, I'm screening for this and this. I'm not loving the way this is showing up. I would like to get another opinion, or I have an expert in knees. I would love to see what they think, and then we will collaborate on your care. I have never had in 25 years one patient that was angry or upset because I wanted to get another opinion that would help them.
Yeah, no. Or when you say, you should maybe go talk to your dentist or oral surgeon or ask for a 3D cone beam.
Right.
What's that? Oh, it's a special kind of in-office CT scan. I can't diagnose anything because I'm just a massage therapist, but some of these things just aren't adding up, and I am concerned about you. Now,
Right.
if you do a 60-minute massage and you take 5 minutes of that, everybody takes a health history, I hope. And which massage therapist is the patient gonna go back to?
Right.
Is the patient gonna go back to the massage therapist that just does a 60-minute massage and they're out? Or is the patient gonna go back to the massage therapist that cares enough
Right.
to check? I'm going with
Absolutely.
they'll be back.
I have discovery calls typically Wednesday morning for potential new patients and clients. And the discovery call is based on the history and for me to look somebody in the eyes to explain what I do. And one of the questions was, if we're already spending half an hour on this call, why do you still need an hour and a half or 2 hours for the first visit?
Sorry.
And I said, what I do is very specific and what I do is very thorough. And I need to have that time the first time you're on the table to be able to fine tune not only what I think I want to do, but to make sure I have enough time to reassess, to treat, to give you exercises, to reassess, to treat, to program. And they were like, wow, this was the most thorough first discovery call I've ever had. I can't wait to come in and see you. So, to your point, I don't think anybody ever is upset at the time we take with patients and clients. And I know for myself, even when we were talking about GPs the other day, you have to make sure you have your list of 2 things and no more than 2 things that you could talk about in a visit, and their hands on the doorknob before they even leave. And I am really excited that I'm in a point in my practice where I can spend time talking to people. And I don't charge for my discovery calls because I also don't want to waste time when people do come in to see me if we're not a good fit, because I am a bit demanding of what I expect. When we are a team, we work together, and there is a buy-in that I need from somebody I'm going to work with.
Yeah.
And it's
Good
okay and it's okay for it to not be a good fit on both people.
Yeah.
So there's that.
I like the way we practice.
Oh, so do I. And I owe so much of it to you and FSM, and I couldn't imagine not practicing this way.
Yeah. And it's, of course, we use a pinwheel.
Yes.
How many times have you been to anybody who doesn't ever check sensation? Excuse me? So, yeah, they've been treating my shoulder.
Yeah.
The physical therapist has been treating my shoulder, and it's up here and it's a biceps tendon thing. And I heard about you and whatever. And it's like, you do the pinwheel, and this is either numb or hypersensitive. And it's like, they've been treating your shoulder. Has anybody checked your neck? No. Why? Because this nerve, the pain in your arm is not from the muscle, it's from the nerve, and the nerve is from here. Put your finger right out there. That's a C5 disc, and we're going to check your neck and treat the nerve. And so the pain is gone in one visit, and we're treating the cause, which is our specialty, is like, where does it come from?
Where does it come from? That is the repeating slide in the FSM rehab. Where is it coming from? How did it get here? We get ourselves into this situation.
Yeah. And it's we did this for treatment. Now, how do you rehab it? So I can't tell you the number of patients where I glide my finger along the chest wall and pull the long thoracic nerve away from the serratus and the lats. That's the start. The rehab course, I hope, is to teach them, how do you activate, how do you change the brain, but how do you strengthen and activate the lat and the serratus, especially the serratus? Who thinks about their serratus? that little teeny muscle that goes from the ribs to the front side of the scapula.
Right.
Why would a muscle do that? That's a silly thing for a muscle to do. But now that I know that it hasn't been firing, because there's no proprioception, you don't know that your serratus hasn't fired for however many years because your lat is glued to your long thoracic nerve until somebody releases your long thoracic nerve and then says, okay, this is how you strengthen it, and I gotta go.
Yeah. And you need to have time and pain-free reps. And this is my love affair right now, is building these. This is going to lead me to a segue of something I want to read really quickly. But the pain-free repetition that we need with confidence is the only way to build the nerves that fire together, wire together, right? We can't get long-lasting success. We can't get long-lasting results in that rehab section if our subconscious is not confident that this is a safe thing to do. And this is where FSM comes into play. There is so many times in regular PT or corrective exercise where we're forcing patients to muscle through a contraction and just keep doing this, and you have to get this strong and have blah 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 blah. And it's not because the patient is not trying. This is a nervous system inhibition for a reason. There was trauma to the area. What do you say? The amygdala gets paid to remember this. So unless we can change that loop, and I have a slide, you will love it. It has the serratus, the lat, and the subscap. And I say these people have to be in a polyamorous codependent relationship.
Exactly.
You will not forget that slide and so we have to get these people to love each other and work together and be dependent on each other for proper scapulohumeral rhythm to occur.
You have to, and explaining to someone why it is you're pinching that little muscle just below their scapula.
Activation.
I want you to pull your shoulder blade down, and they contract the rhomboids and shove it. No, this muscle, not that one, this one. And they contract their jaw, they contract their abs, they contract their butt, they contract everything except they haven't heard from the lower trapezius in ever. There's no, it's what? So it's just, I'm so looking forward to the rehab course. Follow up.
It is the and this is what we get to do. And what I'm loving, and it is just the right time and space for this course. We're learning so much about our ability to move with confidence and safety. And so part of that was spending years with the afraid to move frequencies and putting that in. And now we get to do those exercises, those activations. And one of the other components to confidence, the person has to feel safe you as a therapist have to feel safe to do this, because you give off your confidence to the person.
To teach them, you have to know how to teach them.
Exactly.
The core has changed so much. It's teaching numbers, it's teaching coordination.
Yeah.
And off the bat, from the very beginning, we put in the afraid to move it, coordinate movement, reconnect with the sensory cortex.
Yeah.
All of that is now in every section of the core. Now they know what they need to know to go to the rehab course.
Right.
Now they're sick. How long have we been doing that, you and I? 10 years, 6 years?
I was looking through the contract this morning that we drafted up with the old logo. So that was 2017.
17. So 8 years we've been doing this. And the way the core was structured then, we didn't need it. There really was sports and FSM.
Yeah.
We didn't need a FSM rehab course because I wasn't there.
Yeah.
Now, I've learned so much from you that the core has segued into, there are more practitioners treating patients who need rehab than there are practitioners who treat sport athletes.
And when we think of movement, it's not a sport. Like I said, like a squat could be a squat to an Olympic lifter, or it could just be lowering down to the toilet. It's the same mechanics. We need everybody to move confidently and safely. One of the quote I have
lawn is a sport.
Right. Exactly. I have a really great question that was emailed that I want to touch on. But one of the things before we close this part off is something I want to just mention quickly. So I'll read this first. One of the most important attributes on the path of excellence is fun. Can say that you and I are having fun on our path to excellence right now. Steph
Absolutely.
Curry, as we all know for Warriors basketball, is having a mind-blowing season at age 37. He's dominating a league with players nearly half his age with a smile on his face. Intensity and joy can coexist. Relying predominantly on negative emotions for energy is akin to burning dirty fuel. It's destructive for long-term health of the engine, and it's not sustainable. Joy, on the other hand, is a clean and renewable source of energy. It builds upon itself, doesn't leave toxic pollutants such as resentment and isolation in its wake.
Ooh.
What I wanted to talk very quickly about is I feel like I'm getting a lot of success with patients right now because I'm truly at a point in my practice where I'm having a lot of fun. I enjoy going to work. I enjoy doing what I'm doing. And when I'm writing slides and I'm thinking of the future of FSM and the rehab course, is trying to import that, yes, we have to be confident in what we're doing, but we want patients to have fun. We want them to be excited about their rehabilitation. I don't want to give them another exercise that they're rolling their eyes at that is not going to help. And so to go back with recognizing, again, this is kind of like that vestibular screen. I love how this podcast is going in circles. But to screen for those negative emotions that we see with people who are in chronic pain, like this is, I don't want them to think this is another appointment that they're going to for their condition that is not going to get better. So if we can interrupt that cycle and bring joy and bring confidence to rehab, I think that is such a huge part of the process. And your clinic does such a wonderful job with the art and the pictures, always reminding us of hope.
Yeah. And there was one of the practicum patients, the people at her table, the way her injury happened, she had appendicitis and she was in an ambulance on her way from wherever she was to someplace in Switzerland.
Oh, the abandonment story.
The abandonment story. And it was abandonment, fear,
Sure.
terror, and anger.
Yep.
And that's what made the abdomen soft enough that they could get in and work on the scar tissue. We did talk about that last week because it had just happened.
Yeah. Yeah. It was okay. So we have two on the podcast and I have an email. So I'm going to go to the email one first because I think it's very important. Not that Susanna's aren't either, but
I've got to get to the one about Suzanne's because there was erroneous information.
Okay, go to that one first. Let's get to that one.
Because this one's easy.
Yeah.
I'd like to ask about pacemakers. I see the instructions in the custom care and the precision care to check with the manufacturer. Is pulse EMF safer than going with electric current? No. So that's the first part. The other thing is that those instructions go with the devices because the devices are approved in the category. TENS devices can't be used on somebody with a pacemaker, especially through the chest. Microcurrent is approved in the category of TENS, but it uses 1,000 times less current. So we have had a practitioner who had a Medtronics rep, just that he knew as a friend, come in and check the output and input of the pacemaker while they were running current on it. And if you run above the clavicle and below the waist, it's completely does not change. And I actually was running current through a patient's chest, treating his ribs. And I said, speaking of taking histories, I said, "What's that little scar over there?" He said, "Oh, that's my pacemaker." And it's okay. Took the current off. But he was fine.
Yeah.
When I treat somebody with a pacemaker, I put a pulse oximeter on them. Almost all pacemakers are pulsed, set. The lowest frequency is 60, sometimes 55. And the highest it'll allow before it defibs is 120. So you can go for a fast walk or even a run. And that's how pacemakers work. So you put a pulse oximeter on a patient, you watch their pulse. If it drops below 60, you're messing something up. If it goes above 120, you're messing something up. So you can take the current off and it'll go back to normal. And pulse EMF is affects the monitor. I don't know that it affects the pacemaker any differently. When George was in the hospital, he was on cardiac monitoring because he had left bundle branch block and atrial fib. And we had the magnetic converter on his hip from the fracture and the magnetic converter on his hip after the hip replacement. And the monitor was up and there was no distortion at all. And the nurse walked in and said, "What's that?" And I said, "Well, it's just pulse EMF." And she said, "Oh, okay, that's good. That helps with pain and fracture repair." So
Right.
that's okay.
Yeah.
All right, go.
No, we'll do the other one while we're up here. So
Oh.
benefits of 94 and 94.
It's because Harry said so. That's the short version. Harry Van Gelder treated trauma in the medulla is actually what you have to treat.
Yeah.
If you can't use 94 and 94 because it makes the patient sick, we found out through experience that you could use 40 and 94 and that would be fine. Yeah. And the other thing is that you can run quiet the inner ear and you can usually get away with 94 and 94, but we run it because Harry said so.
And Kim loves it.
And
I can find it in a ballroom of 200 people. I can sniff it out like a drug sniffing dog at the airport. And I'll just
you
like
go stand next to the table.
I'll just drape myself right on that person. I snack off of that curtain
say,
of that frequency all day long.
"Why have you got both your hands on my legs?" I'm just snacking.
Just give me it. Yeah, it just feels so good for me, and I can't get enough of it, and I don't get immune to it. All right, here's the emailed question. I'm going to put it up here. We have a patient who has MCAS, and they went to their doctor who had ran some blood tests to check for possible viral infections. So several came back high, EBV and HSV1 especially. The osteopath is recommending treatment with either herbal remedies or a prescription antiviral medication. Neither of those are good options for this person who is highly sensitive 82-year-old with MCAS. Anything that we can do for FSM?
Oh, yeah. HSV1 and whatever the other one was. Epstein-Barr. Both respond to the shingles protocol. So you park them in a chair, put shingles on it, runs for 2 hours.
Yeah.
And you have them sit in your office, sit in the waiting room.
They have a custom care of themselves.
Just program it with shingles. And only for them, you would call it Epstein EBV.
Yeah.
Or your virus.
Yeah.
Something that the patient will recognize.
Yeah.
And you put it towards the top so they'll use it.
Yes.
So it's like there's no point in burying I've always put the top 10 things they should use. And then the first aid stuff at the bottom.
Right.
You just move
just in cases. Yeah.
And shingles is always at the bottom for everybody except for her. You just take it and you move it up towards the top 10.
And then what do you run it every day, twice a day? What are your...
I guess it just depends. The problem with MCAS is that the vagus is turned off by infection, stress, and trauma. And the vagus suppresses T cells and macrophages. Where does MCAS come from? It does not come from space. It comes from T cells and macrophages.
Yeah.
And then we also have a protocol for histamine that seems to work. You also have to treat leaky gut.
Yep.
I think David Mesnick did a section on MCAS that tells you more than you ever wanted to know.
Yes.
So you just,
This is actual a patient of mine that I treat once a month in clinic, who does have a custom care, is very diligent about everything, has a lot of food sensitivities, is diligent with their diet. And we do have an EBV protocol for her. She has the shingles. And to your point, it always makes me feel so good when I talk to you, is because this is when she brings her custom care to every visit. Sometimes we change things, sometimes we don't, but sometimes there is a reshuffling of the deck where something like shingles might have been at the bottom because we're like, just in case, and now we just float that one up to the top. And you've got a great SIBO program on there.
Leaky gut with MCAS, leaky gut is like the thing. You've
Yeah.
got to repair the gut. And for most people, even though they don't want to spend the money, this protocol is 2 hours and 14 minutes long.
Yeah.
Is there a time during your day when you're going to want to sit there with wet things on you for 2 hours and 14 minutes?
It also has a magnetic converter, so
there
that
you go.
you can put things to bed.
Yes, you take
Yes.
it. And what's possible with the new software is you can stack. You just make a nighttime program and you can stack shingles, turn on the vagus, treat the leaky gut, treat the SIBO, treat the MCAS. So turn down the histamine.
Yeah.
You can do all that. The program is going to run 4 hours, but she better be sleeping at least 4 hours.
Right.
So
Yeah.
that's a good one.
Yeah, and that is the great thing about the magnetic converters. There's so many things that you can just run at nighttime, and you don't have to worry about sticking electrodes on you, and just tuck yourself in with that. That's what you do. Yes.
Oh.
And people are always asking about the difference, like what happens with the magnetic converter versus not using it, and is there an application that's better or worse? We used to say treating nerve pain wasn't as effective with the magnetic converter. However, you are proving that wrong all the time, because
every now and then,
yeah,
my hand will light up and I would put the one puck here at my neck and the other one in my hand. It has to be run alternating.
Yeah.
If you're dealing with long-standing nerve pain,
Yeah.
it's current, where the nerve starts to where the nerve ends. And then at that time, you have to release the adhesions and do all the rest of that. But so it's better to treat it at first and then use the converter alternating as a rescue.
Right.
If they do something that tractions it, or they run into scar tissue that we all thought it was gone,
Right.
they need to have a way of treating their nerve pain if it lights up again.
Right.
Or if they do something silly, like, you've been over and did what? Okay, yes, that would be why your heel and your foot hurt. So you put one puck at your back and put the other one, tape it to your foot at night, and climb into bed with your converter. That'll work.
There is a follow-up question that just popped up while we're talking about the converters. Do FSM programs work as well with magnetic converters as they only do positive? Historically, pulsed EMF or PEMF machine treatments have done nothing for me, so I've been reluctant to spend $2,000 for converters. Thoughts?
Oh, yeah. Every other pulsed EMF device on the planet is not specific. Like they do 0.3 of a hertz, like the Beamer.
Yeah.
Some of them will have 0.3, 330. They'll have a sequence, but most pulsed EMF devices only run one channel. And the field has to be strong enough. So there's one gadget out there that attaches to a cell phone and it does do frequencies, but the field is 1200, 1500 milligauss, and the magnetic converter is 3600. Field strength makes a difference, apparently, because I've had people have that discussion with me. That thing doesn't work, so why will this work? Oh, ND used a big machine with it. Yeah, no, it's still not specific. So the naturopath, Sherry says the naturopath used a big pulsed EMF device with a circular field. That is a, how would I put it, a sales phrase? It's still only one frequency,
Yeah.
or it'll do a sweep, but it doesn't do what our magnetic converter does. So the other thing you can do with the patient in your office, I keep a magnetic converter in the office. I never use it because I always think it's like just a step too far.
Yeah.
I'm a chiropractor. I may be all over the internet, but I'm still a chiropractor. And I'm using frequencies you can't hear and current you can't feel.
Right.
And using something with blinky lights is just too much.
Yeah.
No,
Yeah.
I have my limits.
Right. Yeah. But if your patient brings their own in with the magnetic converter, then that's a different story. And then
Absolutely.
I always tell people bring their machines in because you can never have too many in the clinic. So bring it into program for me to program, but we also might use it during the treatment as well, because you can never have too much. The alarm is going off. It's 4 o'clock.
It is not.
I promise you it is. Again, so my closing things until the advance is register for the advance, especially because we have amazing sales between now and the end of the year. So there's that.
And it is, I hate to keep saying this to people, but I'm 79. This is the only 4-day advanced. We may do one in 28, but next year we're back to a 2-day. And then the year after that, if I'm still, I had my staff, I had everybody, including you, promise me that you'd tell me when I lose it. There are people that are still giving lectures at 85 that really should not.
Yeah.
So if I'm still alive and able to handle a room,
Yeah.
I'm 81, 82, then we'll have a 4-day advanced in 28 and then we'll see. But it's going to be different. If you've been to the advanced before, yes, we're going to live stream it, but there's something really special about being there in person. It's like going to Costa Rica. You just sit at a table. This is the only it's not a profession, but it's not even a technology. I don't even know. I don't know what to call us anymore.
No.
Technology. It's not a technology. It's whatever. It's the only thing, the only technique you're going to use where you will sit at a table with massage therapists, MDs, DOs, naturopaths, occupational therapists, physical therapists, neurosurgeons, neurologists,
Orthopedic surgeon. We'll bring one in this time.
orthopedic surgeons. It's PM&R.
Yeah.
Nurse. I get in trouble because I always forget nurse practitioners.
Yeah.
And PAs. It's like
we all speak the same language and love and respect each other, and you get to talk in numbers.
Yeah, and it's the only place.
Really good food and get good sunshine.
Oh, sunshine and food, and we're doing it in March, so we're further away from the rainy season.
Yeah.
And it's the only place, honestly, where you feel normal.
Yep.
You can't go to a PT conference and say it's easy. It was nerve pain.
Yeah. And wait for lightning to strike you. Yeah, so come, and it's going to be special. And I know we say it every year, but it's especially true this year.
Yeah.
And I have to go, and it's 4.
Okay.
So we did it, and we'll see you next week, and we'll see everybody back here next week.
See you next week.
See you then.
Bye.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts, or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.